This is still continuing for Lecture 1, Chapter 4, Stretching for Improved Mobility. The definition and purpose. So, stretching interventions when restricted mobility adversely affects function, reduce the risk of injury or re-injury. Stretching is a general term used to describe any therapeutic maneuver designed to increase soft tissue extensibility with the intent of improving flexibility and range of motion by elongating or lengthening structures that have adaptively shortened and have become immobile. Flexibility. There's dynamic flexibility and passive flexibility, as well as hypomobility. So flexibility is the ability to rotate a single joint or a series of joints smoothly and easily through an unrestricted, pain-free range of motion. Muscle length, joint integrity, and pre-articular soft tissue extensibility all interact to determine flexibility. Flexibility is maximized when the muscle tendon units that cross a joint have adequate extensibility to deform and yield to a stretch force. So in addition, the arithrokinematics of the moving joint, which is the ability of the joint surfaces to roll and slide, and the ability of peri-articular connective tissues to deform also affect joint range of motion and flexibility. Dynamic flexibility, this is a form of flexibility that's also referred to as active mobility or active range of motion, is the extent to which an active muscle contraction can rotate a joint through its available range of motion. Dynamic flexibility depends on the ability of a muscle to contract through the range of motion and on the degree and equality of tissue extensibility. Passive flexibility, also referred to as passive mobility or passive range of motion, is the extent to which a joint can passively be rotated through its available range of motion and depends on the extensibility of soft tissues that cross and surround a joint. Passive flexibility is a prerequisite for, but does not ensure, dynamic flexibility. Hypomobility, if you will please review, it's obviously we have went over this in 101 and 150, is the decreased mobility or restricted motion at a single joint or series of joints, which might be because of several different pathological processes that would be contributing to the limitation of range of motion. So these factors are summarized in Table 4.1. Contracture. So a contracture is a restricted motion, can range from mild tightness to irreversible contractures. Contracture is defined as the adaptive shortening of the muscle tendon unit and other tissues that cross or surround a joint, resulting in significant resistance to passive or active stretch and limited range of motion. The limitations associated with contractures can significantly compromise functional abilities. So contractures are described as the side of the joint that has the tissue tightness. If the tightness is on the flexion side of the flexion extension joint axis, it is called a flexion contracture. For a patient that has a shortened elbow flexor who cannot fully extend the elbow, they are said to have an elbow flexion contracture. The patient with a tight hip adductor who cannot fully abduct the leg is said to have a hip adduction contracture. So contracture versus contraction. The terms contracture and contraction, the process of active tension developing in a muscle during shortening or lengthening. These are not synonymous and not to be used interchangeably. So types of contracture. So there are myostatic contracture. A myostatic contracture, although the musculotendinous unit has adaptively shortened and there's a significant loss of range of motion, there's no specific muscle pathology present. There is a reduction in the number of sarcomere units in series, and there is no decrease in individual sarcomere length, and myostatic contracture can be resolved in a relatively short time with stretching exercises. A pseudomyostatic contracture is impaired mobility and limited range of motion, result of hypertonicity, which could be spasticity or rigidity, associated with the central nervous system lesion, such as a CVA, a spinal cord injury, or traumatic brain injury. There is muscle spasm and guarding and pain with a pseudomyostatic contracture. In both situations, the involved muscle appears to be in a constant state of contraction, giving rise to excessive resistance to passive stretch. If a neuromuscular inhibition procedure to reduce muscle tension temporarily is applied, a full passive elongation of the apparently shortened muscle is then possible. Arthrogenic and periarticular contracture is a result of interarticular pathology. These changes may include adhesions, synovial proliferation, joint effusion, irregulars in articular cartilage, or osteophyte formation. A periarticular contracture develops when connective tissues that cross or attach to a joint or the joint capsule lose mobility, restricting normal orthokinematic motion. A fibrotic contracture, or a irreversible contracture. So fibrous changes in the connective tissue of muscle and periarticular structures can cause adherence of these tissues and subsequent development of fibrotic contracture. Although it is possible to stretch a fibrotic contracture and eventually increase range of motion, it is often difficult to reestablish optimal tissue length. Permanent loss of soft tissue extensibility that cannot be reversed by non-surgical intervention may occur when normal muscle and organized connective tissue are replaced with a large amount of relatively non-extensible fibrotic adhesion, scar tissue, or herniotrophic bone. These changes can occur after long periods of immobilization with tissues in a shortened position or after tissue trauma and the subsequent inflammatory response. The longer a fibrotic contracture exists or the more extensive the tissue replacement, the more difficult it becomes to regain optimal mobility, and the more likely it is that the contracture will become irreversible. For an example, in the clinic, I have seen, especially for shoulder injuries or those that have were not compliant with the surgeon and they did not come to their therapy sessions after surgery for maybe a prolonged period of time, and they were having immobilization of the glenohumeral joint, they might have permanent damage to where you would not be able to achieve full range of motion even after having different periods of coming to rehabilitation. Another example would be, I've known other patients to have to maybe they've had adhesive capsulitis and with therapy did not improve the changes, and they would have to go in and surgically improve the joint for increased mobility. Selective stretching is a process whereby the overall function of a patient may be improved by applying stretching techniques to some muscles and joints, while allowing motion limitations to develop in other muscles or joints. When determining which muscles to stretch and which to allow to become slightly shortened, you as a therapist must always keep in mind the functional needs of the patient and the importance of maintaining a balance between mobility and stability for maximum functional performance. The decision to allow restrictions to develop in selected muscle tendon units and joints typically is made in patients with permanent paralysis. So, for example, in a patient with a spinal cord injury, stability of the trunk is necessary for independence in sitting. With thoracic and cervical lesions, the patient does not have active control of the back extensors. If the hamstrings are routinely stretched to improve or maintain their extensibility, and moderate hypomobility is allowed to develop in the extensors of the low back, this enables the patient to lean into the slightly shortened structures and have some degree of trunk stability for long-term sitting. However, the patient must still have enough flexibility for independence in dressing and transfers. Too much limitation of motion in the low back can decrease function. Allowing slight hypomobility to develop in the long flexors of the fingers while maintaining mobility of the wrist extensors enables the patient with a spinal cord injury who lacks innervation of the intrinsic finger muscles to regain the ability to grasp by using a tenodesis action. Overstretching and hypermobility. Overstretching is a stretch well beyond the normal length of a muscle in range of motion of a joint and the surrounding soft tissues, resulting in hypermobility or excessive mobility. So creating selective hypermobility by overstretching may be necessary for certain healthy individuals, those that maybe participate in sports such as a baseball pitcher, that require extensive flexibility. Hypermobility can create detrimental joint instability if the static supporting structures and or the dynamic muscular control of the joint are unable to maintain the joint in a stable, functional position during activities. Instability of joint could cause pain and may predispose a person to musculoskeletal injury. So, for example, I've had some patients, typically younger, that had between their teens and their 20s, that might have hypermobility and causing increased pain. So, as we perform interventions to decrease pain and to improve with strengthening, a lot of times their pain will decrease. There are many therapeutic interventions that are designed to improve the mobility of soft tissues to increase range of motion and flexibility. Stretching and mobilization are general terms that describe any therapeutic maneuver that increases extensibility of restricted soft tissues. Some other types of interventions would be manual mechanical stretching, passive and assisted stretching, self-stretching, and neuromuscular facilitation and inhibition techniques can also be referred to as PNF patterns. So stretching, manual or mechanical, passive or assisted. So an in-range stretch force will elongate shortened muscle tendon units and or periarticular connective tissues when a restricted joint is rotated just beyond its available range of motion. The force can be applied by manual contact or mechanical device. It can be sustained or intermittent. When the patient is as relaxed as possible during the stretch, it is called passive stretching. If a patient insists on moving the joint through a greater range, it's called assisted stretching, or which is different from range of motion. Okay, so there's active range of motion, active assisted range of motion, and passive range of motion. But here we are referring to stretching. Self-stretching is as it sounds. They perform stretches that you would educate them through. Neuromuscular facilitation and inhibition techniques. So neuromuscular are founded on the concept of relatively decreased tension in shortened muscles prior to or during the stretch, because the use of inhibition or facilitation techniques to assist with muscle elongation is associated with approach to exercise known as PNF, proprioceptive neuromuscular facilitation. Many clinicians and authors refer to these as procedures as PNF stretching, active inhibition, active stretching, or facilitated stretching. Later on in the chapter, we will discuss more on the principles of PNF. Muscle energy techniques are manipulative procedures that are evolved out of osteopathic medicine designed to lengthen muscle and fascia and to mobilize joints. The procedures employ voluntary muscle contractions by the patient in a precisely controlled direction and intensity against a counterforce applied by the practitioner. As demonstrated last semester in PTA 150, I showed you a muscle energy technique for leg discrepancy. If you can refer back to that, and I believe that there were videos as well. Joint mobilization and manipulation, which we'll talk about in the next chapter. So I'm going to skip over that. Soft tissue mobilization we'll also talk about next chapter, but they are soft tissue manipulative techniques that are designed to improve the extensibility of any soft tissue that limits mobility. These techniques are specific and progressive manual forces, utilizing sustained manual pressure or slow deep stroking. Neural tissue mobilization are techniques used to improve or restore nerve tissue mobility. Nerve tissue mobility may become restricted by tissue adhesions or scar tissue following trauma or surgical procedures. Now we're moving on to indications, contraindications, and potential outcomes of stretching exercises. So indications and contraindications for stretching. There are situations in which stretching exercises are appropriate and safe. However, there are also instances when stretching should not be performed. If you look at box 4.1 and 4.2, they list the indications and contraindications for the use of stretching interventions, which we'll go over those in just a minute. For increased flexibility and range of motion, the expected outcome of stretching exercise is to restore and increase muscle tendon unit extensibility to regain or achieve the flexibility and range of motion required for functional activities. As discussed throughout the chapter, we will be talking about body of evidence shown as stretching, particular static and PNF stretching procedures, improve flexibility, and increasing range of motion. You will need to know the parameters of stretching exercises to determine effectiveness, such as intensity, duration, and frequency, that we will talk later on. And here's the list of indications for stretching. So if there's adhesions, contractures, or scar tissue, limited range of motion, potential for structural deformity, diagnosis, treatment, limited range of motion. If there's muscle weakness, shortening of muscles, part of a total fitness program, or pre and post vigorous exercise. Some common conditions related to the immobility would be prolonged immobilization, restricted mobility, connective tissue disease, neuromuscular disease, tissue pathology due to trauma, congenital and acquired bone deformities. So here's a clinical question. Why should the rectus femoris be stretched and prone instead of standing? For example, which position is best for stabilizing the pelvis? Well, prone helps stabilize the pelvis in neutral position or hip extension. Standing has tendency to flex the hip, which equals poor quality of a stretch. The patient can be in side lying, supine, or standing to stretch rectus femoris as long as their therapist assists patient in proper hip position. Here is the list of contraindications, which I'll talk more in depth, but this is on box 4.2 in your textbooks. But bony block, non-union fracture, acute inflammation or infection, sharp or acute pain with elongation, hematoma or tissue trauma, hypermobility. Hypermobility provides stability or control.